Dr. Jitender.
This one, Divya Srivastava.
Good morning, everyone. So I'm Dr. Jitender. I'm working as assistant professor in PGIMS Chandigarh. So I will present my free paper on age-stratified analysis of ocular cicatricial pemphigoid. So as we know that OCP is an autoimmune disorder which is quite rare, but it is characterized by progressive inflammation and scarring of conjunctiva, which lead to severe ocular surface disease and irreversible vision loss. So literature review suggests that clinical presentation of OCP varies widely, may be influenced by factors such as age, gender, race, systemic involvement, and coexisting autoimmune conditions. So we try to find out any difference in disease behavior and management strategies between the two age groups, and this study seeks to contribute to a personalized approach to care of these patients. So objective was to study demographic, clinical features, diagnostic and management strategies in younger, less than 15 years of age, versus an older, more than 15 years of age of patients of OCP at the time of presentation. So it was conducted at a tertiary eye care institution in North India. So medical records were analyzed between the period of August 2019 and July 2024 after taking ethical approval from the institute. The patients were categorized as I have described. The two groups were compared in terms of age, gender, visual acuity, disease, clinical severity score, staging of the disease, complications, and management strategies. Appropriate statistical tests were utilized. So coming to the results, total 43 patients were included in the study. 17 patients of 34 eyes were in group 1 and 26 patients with 52 eyes were analyzed in group 2. So mean age at presentation was 25 years in group 1 and around 65 years in group 2. P-value was significant for the age difference. Duration of symptoms before the diagnosis was similar between the two groups. There was no statistically significant difference. On an average, it was 53 for the group 1 and 55 months for the group 2. So gender distribution was different in both age groups. Younger groups had more male patients as compared to the older groups in which female preponderance was noted. The diagnostic test, the direct immunofluorescence, which is used to diagnose the OCP, was noted significantly higher positivity rate in the younger group as compared to the older group. Visual acuity at presentation was significantly worse in the older group. This suggests that older patients present with more visual acuity impairment because of advanced ocular surface changes at the time of diagnosis. The mean Foster state as a presentation was higher in older group. This implies that at the time of presentation, the disease was already progressed in the older group. The patient in younger group presented the unilateral findings, and in all these patients, the OCP were diagnosed later in the other eye also. So this suggests a higher index of suspicion in younger patients is important to diagnose OCP. The conjunctival clinical activity score was higher in group 1, but it was not statistically significant. Multi-system involvement was noted more commonly in the younger group. Oral mucosa was involved most commonly. However, the genital mucosa were involvement in the younger patients. Patients with coexistent disease like rheumatoid arthritis, Sjogren's syndrome, TB were more commonly noted in the older group, which highlights the higher burden of these autoimmune disease in older patients. Choice of immunosuppressive therapy differed in two groups. While the younger group was treated mostly with the azathioprine or mycophenolate mofetil, and cyclophosphamide was utilized more commonly in the older group. However, rituximab was used as a second-line treatment in both the groups. Corneal involvement was noted similarly across the groups, and the need of the surgery like amniotic membrane, eyelid surgery, corneal perforation surgery, cataract surgery was noted comparable in the both the groups. So this is the summary of all the findings. And this study has some important implication on the management of OCP. The higher stage of the disease at the time of presentation in the older group underscores the need of the early diagnosis and management in this population. For the younger patients, rate of biopsy positivity is higher, so disease can be picked up and treated confidently in the younger group. Comparable rate of complications between the two groups such that the age alone should not be dictate treatment intensity. Instead, management strategies should be tailored to the individual patient, taking into account the disease severity, comorbidities, and treatment outcome. This study has few limitations, like it was a single center-based study, and it was retrospective design and relatively smaller sample size, which may induce bias and limit the generalizability of the findings. So conclude, this study highlights the need of age-specific approaches to the diagnosis and treatment of OCP, with an emphasis on the higher suspicion, early biopsy, early medical intervention, and individualized therapy. By addressing the unique challenges in different age groups, clinician can optimize outcomes and improve the quality of life for the patient with this debilitating condition. These are my references. Thank you.
I would like to congratulate you for conducting this very nice study. So finally, your carry-home message will be?
The carry-home message is that if a patient presents with the features of cicatricial conjunctivitis in the younger age group, which is generally ignored, we should have a lower threshold to send the biopsy, because biopsy positivity rate is much higher in the younger group. If we have a positive biopsy reports with us, we are confident in treating the patients, which are generally ignored in the younger age. And for older patients, again, literature suggests that most of the patients present in the older age group, but their biopsy positivity rate goes down because of the scarring of the conjunctiva. So in those patients, we should try to develop some mechanisms to detect them at early stage, so that the ocular surface changes doesn't progress much.
So what were your initial signs or symptoms, especially in young patients, whether to send the biopsy or not?
So basically, we follow a protocol in which we have used cicatricial conjunctivitis score developed by Basu and Sanbhag et al. So we say that if we have a set of signs and symptoms and clinical findings, and if the score is more than 5, we exclude a most common diagnosis called Stevens-Johnson syndrome. So for rest of the patients which have score less than 5, we send the conjunctival biopsy, oral mucosal biopsy, and if any of them comes positive, we diagnose and label them as biopsy proven OCP. Although there are so many other differential diagnoses of this condition, but we try to rule out them on the basis of clinical history and examination.
Are these patients not associated with atopy or type 1, type 2 hypersensitivity?
No, sir. Actually, these diseases have altogether different pathogenesis than allergic eye conditions. It is a disease which is a part of mucous membrane pemphigoid, which we see in the dermatological conditions.
So it's a type 2 hypersensitivity reaction where
Antigen antibody complex deposited at the basement
Deposited
membrane.
at the
Yeah, type 2 you can say.
What is the youngest age you identify?
Actually, ma'am, we have, in this study, it was 13-year-old, but now we have a patient who's 8-year-old also, which is being followed mainly in the dermatology department, but he has very slight early.
Any family history in those patients?
No, mostly these patients don't have any family history. So etiology is not clear for this disease, but a lot of research need to be done to find out.
Treatment in all these patients for biopsy positive?
Yeah, actually, ma'am, the treatment is, tailorized as per the need of the patient. If there is a lot of inflammation in the conjunctiva and we think that it is going to worsen the, ocular surface disease, so we have to start immunosuppressive therapy. But since the patients are young, so we have to think in that we also like that the treatment itself may lead to a lot of other problems. So as per requirement of the ocular inflammation, we start the treatment.
So you have to do it with the immunologist always?
We are doing, ma'am, with the teamwork, like dermatologists and immunologists are involved.
And one more question. These patients, most commonly, how do they present to your OPD? These youngsters, with what symptoms do they come?
Actually, they present with a lot of conjunctival inflammation. Sometimes they present with non-healing recurrent corneal epithelial defects, sometimes superadded infection. And these all patients have some kind of cicatrizing changes in the lower fornix and the tarsal, fibrotic. If you invert the upper eyelid, you see a lot of tarsal scarring. And sometimes they have dry eyes also. It is believed that OCP lead to dry eyes in the later stages, but our findings are, we noted some different presentation. They have early dry eye also, because lacrimal gland area has gotten scarred earlier in the disease, then they have very low tear production. Like somebody has shown DATS, dynamic assessment tear excretion. So we do that also. We see that they don't secrete much tear from the lacrimal glands.
Thank you very much.